Next, we have a guest lecture chaired by Dr. Pichumani sir, MD in Internal Medicine, DCH, Director and Consultant Diabetologist in Sri Ranga Hospital, Chengalpattu. We have a speaker, Dr. Cynthia Mohandas ma'am, MBBS, FRCP, MRCP Endocrinology and Diabetology UK, Consultant Diabetologist and Endocrinologist in Darren Valley Hospital, Kent. She will be talking on cardio-renal metabolic approach for type 2 diabetes mellitus and the role of SGLT2. Ma'am will be joining us online.
Hello, I'm Dr. Cynthia Mohandas, one of the consultants in diabetes and endocrinology from UK. And thank you for inviting me to present on this very important topic of cardio-renal metabolic approach for type 2 diabetes and the role of SGLT2 inhibitors. These are my conflicts of interest. And as we all know, diabetes is a large and growing global epidemic. 1 in 11 adults globally have diabetes. And in 2017, there were 425 million people with diabetes. And in 2045, it will be 629 million. And 80% of the diabetes burden is in low and middle income countries such as Asia and Africa. And also 30 to 80% of people with diabetes are undiagnosed depending on the screening programs in the country. So what I have shown in this slide is about a retrospective analysis of data from more than 1.1 million patients with type 2 diabetes. And initially you can see 66% of the patients were cardiovascular and renal disease free. But when they were followed up for 4.5 years, it was only 18%. And on your right, you could see that compared with comorbidity-free patients with type 2 diabetes, cardiorenal disease was associated with greater risk of mortality than stroke, peripheral arterial disease, and MI. And from this slide, it is very clear that type 2 diabetes and cardiorenal disease are interlinked, and cardiorenal disease is the most frequent first comorbidity in type 2 diabetes, and it is associated with high risk of death and cardiovascular complications. Again, this forest plot clearly shows that glucose lowering alone has minimal impact on reducing heart failure events. So initially, diabetologists all over the world were only interested in lowering the sugars, and we were very much glucocentric. But following the trials, such as ACCORD, it became very clear that intense lowering can cause more harm than good. So basically, we knew that glucose lowering alone was not important. Unlike MI, residual heart failure risk still remains a big problem despite optimal control of traditional cardiovascular risk factors, which is all listed here, which is this HbA1c, LDL, albuminuria, smoking, and blood pressure. Optimal risk factor management does not eliminate the risk of diabetic CKD, which is the same as we spoke in other slides about cardiovascular disease and heart failure. So, in summary, heart failure and CKD are the most frequent first comorbidities in type 2 diabetes and are associated with a high risk of death and further cardiovascular disease complication. Heart failure is the most common reason for cardiovascular disease-related hospitalization in type 2 diabetes. Only controlling of HbA1c and traditional risk factors, which I listed, does not remove the risk of diabetic heart failure events or CKD development. Both CKD and heart failure increase the risk of cardiovascular and all-cause mortality in type 2 diabetes. So what next? Then the whole world went through a paradigm shift. As I said initially, it was all glucocentric, but in 2007, there were concerns regarding certain drugs, especially rosiglitazone, because it was linked with MI and heart failure. And in 2008, FDA issued guidance to all the pharmaceutical industries, setting out new expectations for development of anti-diabetes drugs for type 2 diabetes. All drugs which were developed later needed to have cardiovascular outcome trial evidence to avail concerns regarding their safety profile. And thus emerged the SGLT2 inhibitors. I'm sure the other speakers are going to take you through the pathophysiology. So I will just focus on what is the topic. So the mode of action decreases glucose reabsorption and lowers blood glucose. So the benefits, as the diabetologist I see, is establishing efficacy, which is HbA1c reduction of 0.5 to 1%. And in IFCC, it is 5.5 to 11 millimole per mole. There's weight reduction, there's low risk of hypoglycemia compared to sulfonylureas, reduction in blood pressure, reduced cardiovascular risk, and renal benefits. What we should be careful as diabetologists, as the cardiologists and nephrologists are started to do joint renal clinic, is to make sure that we reassure the patients about the side effects, which is UTIs and genital tract infection, the risk of volume depletion. So when they have a diarrheal illness or viral illness, and the whole world went through COVID. So at that time, you have to be careful and you have to give the sick day rules. What we call as a sick day rules is when a patient is not eating and drinking, and when they are not able to keep any food or fluids in, they should not be taking the tablets. By that simple measure, we can reduce DKA, which is a very rare complication, but euglycemic ketoacidosis is quite common. And even in our hospital, we see 1 or 2 a month when these rules are not followed. Fournier's gangrene in men is very rare, and I haven't seen many in the last few years. Lower limb amputation was especially linked to a study with canagliflozin, and that was 4-foot amputation. And in our trust, in our hospital, we avoid cana and we use more of dapagliflozin and empagliflozin all over the NHS in UK. So the evidence, what is the evidence across the SGLT2 cardiovascular outcome? As you can see in the lower half of the pyramid, diabetes and multiple risk factors were studied, mainly with dapagliflozin, and SGLT2 reduces heart failure hospitalization and renal events, but do not impact atherosclerotic events for primary prevention. However, a majority of population studied in the EMPA-REG trial had already, had diabetes as well as established cardiovascular disease. And this was a secondary prevention population. And in this population, SGLT2 reduces heart failure hospitalization, renal, as well as atherosclerotic events. And this is a table which gives you a list of the various benefits. And as I have clearly pointed out in NHS, we use empagliflozin as secondary prevention and DAPA in heart failure, as well as it's got a renal license with the eGFR of less than 15, up to 15. So we do use quite a lot. And as you know, the United Kingdom is very conventional and side effects really scare the authorities. And we do not use canagliflozin, although it is used in few centers. And you can see it is non-inferior and superior. It does reduce heart failure and renal composite, but we all know as diabetologists, apart from SGLT2 inhibition, cana also has SGLT1 inhibition. So what is it compared to other drugs? Compared to sulfonylurea as a class, SGLT2 inhibitors were associated with a reduced risk in death and acute ACS events. And emerging evidence suggests that SGLT2 inhibitors and GLP-1 analogs are associated with significantly lower cardiovascular mortality and heart failure events compared with DPP-4 inhibitors. And that is what this forest plot clearly shows. Now, what does all the guidance in the world and the guidelines in the world says? As you can see, I have plotted the various guidelines we use in our clinical practice in UK. So SIGN stands for the Scottish Guidelines, ADA, as you know, is the American Guidelines, ADA Society, and EASD is the European Association for the Study of Diabetes. And again, it was updated from 2018, 2019. And finally, there was an ICGP guideline, which is an Irish guideline. And finally, the NICE, which is the main authority recently, National Institute for Health and Care Excellence in UK was updated in June 2022. And all the updated national and international guidelines position SGLT2 inhibitors ahead of sulfonylureas and DPP4 inhibitors for many patient groups. Here, I would just ask, I do not work currently in India, as you know, but it is important that the practice across all over India should have some uniformity, because I know there are centers of excellence, but I'm not sure if the same is true of small towns and villages. So it'll be really good to know the practice across the nation and have some common guidance in keeping with the evidence. So this is what I've talked about the ADA, and you can clearly see that if you have atherosclerotic cardiovascular disease, GLP-1 or SGLT2 is with proven benefit is used. And if you have clearly heart failure, CKD, SGLT2 is the drug of choice. And this is our new NICE guidance. And now it recommends that for type 2, treatment choices should be based on metabolic response, cardiovascular, and renal protection. If you remember, when I presented this talk in 2015, we didn't have this guidance, and it was all metformin, glycoside, and based on cost implication. As you know, NHS is free for all population, so still cost-benefit analysis comes into play, but at least, NICE has suggested that we can use SGLT2, which wasn't the case before. So the first treatment is still, if you don't have cardiovascular risk, is metformin, and then they ask you to consider all the drugs, but we clinicians go for SGLT2. And if there's high risk of cardiovascular disease with a Q2 score of 10% or higher, we offer metformin, and if it's contraindicated, to consider SGLT2 inhibitor. And again, with chronic heart failure and atherosclerotic cardiovascular disease, obviously, metformin and SGLT2, or we use SGLT2 alone if metformin is not tolerated by patients. So, in summary, therapy choice should be individualized to achieve treatment goals that are tailored to the needs and circumstances of the patient based on recent evidence. As you know, the patient in front of you will not fit all the world criteria. They might have cardiovascular disease, but at the same time, they might have side effects which prevent them from using a particular drug. In UK especially, we have a big population who are frail and elderly, about 80%, about 80 years, and they actually form about 60 to 70% of admissions in the hospital. And when they are admitted, and if we use cheap drugs such as sulfonylureas, obviously it increases the risk of falls, and also it prolongs your hospital stay. So obviously we are making a case for these new drugs despite the cost implications. And as you know, the systems in all over the world are different. Again, in UK, a large proportion of the type 2 diabetes is not managed by specialists. It is managed by general physicians, GPs. So we do a lot of education for GPs, and GPs have a lot of courses to upskill themselves, because understanding a cardio-renal metabolic approach is the key to improve patient outcomes. And everybody who's looking after patients with diabetes need to be aware of the new guidance, the new evidence which is emerging in the world. And it is not limited, as we know, to the diabetologist. SGLT2, as you know, is already used by our renal physicians, independent of diabetes, and it's also used by cardiologists for heart failure. So everybody needs to know the side effects of the drugs, the doses of the drugs, and on which patient groups to use. And obviously now, finally, the world has caught up, and national and international clinical guidelines have been updated and position SGLT2 inhibitors and GLP-1 agonists ahead of sulfonylureas and DPP4 for their multiple benefits, as already outlined in this talk, including cardiovascular and renal benefits. So when we speak to GPs, we give them a very simple algorithm: metformin first, and then SGLT2 and GLP-1. I think that's the future or the huge paradigm shift. And the other drugs, they are good. They are used for individualized patients when they are needed for a particular condition or a patient group. But on the whole, the cardio-renal metabolic approach is being followed all over the world now. What is the future direction? Cardiorenal metabolic disease is a complex condition which is associated with significant morbidity and mortality that requires a collaborative approach between diabetes, cardiology, and nephrology MDTs. As you know, in NHS, the cost savings are very important, and all over the country, there are joint clinics between the three specialists. It is very hard to bring the three specialties together, but it is very beneficial for the patient. Just imagine the patients attending multiple hospital appointments, and the cost as well as the inconvenience for the older patients is avoided by having three specialists in one clinic, and it is huge savings for the NHS or whichever organization which undertakes this. So the joint cardio-renal metabolic approach leads to a unified management plan that is conveyed very clearly to the patients and also to the primary care and community teams, leading to streamlined care and leads to better patient outcomes and satisfaction. And also it is cost effective. So that is what I would recommend from this talk, to take away and think about collaborating with your colleagues in your own little hospitals and in your towns, because that is going to be hugely benefit. Otherwise, the patients will be seeking first and second and third opinion. But having a unified management approach, really gives them a confidence in clinicians and also improves their compliance and outcome. With this statement, I'd like to thank you all for this opportunity. And I'd like to say that it's important now to join hands with other colleagues to create, a bigger vision, and also for bringing the diabetes world together and fighting this epidemic together. Thank you very much. These are my contact information. Thank you.
Thank you very much for a wonderful lecture. Since today morning, we have been hearing these lectures, and we are not very much far behind in India, because we've been doing the same thing. And of course, we are almost up to date, and we're quite happy that the education programs that we've been conducting for the GPs over there. I think this entire concept of GCDC is actually educating the general physicians and general practitioners who are involving the almost primary care of diabetes, and of course, they do manage the cardiac patients also. Thanks a lot for the interesting lecture. I think if there are any questions, we'll take it up. I'm not able to hear your voice, please. Not able to hear your voice.
Oh dear.
Okay, fine. Yeah.
Can you hear me now?
Yeah, please.
Yes, good. So thank you so much for giving the opportunity. Thanks to Dr. Professor Arunraj and Aarti. I've grown in Tuticorin, and I'm really proud to give this lecture to the Indian audience, and I'm glad you're all doing a good job there as well. I think NHS probably needs more funding, and we need to keep up with the rest of the world. But I think the point I was trying to make is to kind of have joint clinic approach, and even in NHS, that's a new concept. And that will be really good, because I'm sure, in big cities it's happening, but to kind of take it across to the towns in Tamil Nadu will be a great vision to accomplish.
Thank you.
Any questions?
Yeah.
Hi, I'm Dr. Nihar Mehta. I had a question, a little more practical question in terms of the Indian context. So very often we come across patients who come with a pre-existing prescription of a sulfonylurea with metformin, and they're taking this for a long time, and they are absolutely well controlled with controlled HbA1cs. Now, with the new evidence that we have, would we recommend them shifting from these older and cheaper drugs to the newer and obviously the metabolically more sound drugs? So what would you recommend for these well-controlled patients? And we do come across a lot of them who are well-controlled, but should we be offering them newer drugs or not?
That's a very good question, and I get that often asked by many colleagues. And as I clearly pointed out in my talk, it's not the glucocentric focus. So if they have, as you know, very clearly in the guidance, a cardiovascular disease or renal disease, as you know, it is independent of the well glucose control, really well managed diabetes. So what we do is, of course, we add on, one of the SGLT2 inhibitors, depending on the risk factors. Obviously, if they don't have any risk factors, of course, leave them alone. But if they have risk factors, which I think most of our Indian population has, it is really good to add on a SGLT2 inhibitor. And I usually would not stop, obviously, reduce the dose of sulfonylurea accordingly. But I think I would not deprive them of the benefit of adding an SGLT2, having seen so much evidence.
Thank you, Dr. Cynthia, for your excellent lecture. I think we are going to move to the next lecture here. Thank you. Thanks for sharing your thoughts.
Thank you very much.
Bye.
Thank you. Bye.
MD Medicine, GNB in Medicine, FRCP London, and GNB in Cardiology. Sir's special interests are structural heart disease, TAVR, Mitra clips, and CAVI. Sir has performed the first Mitra clip cases in Western India, and now he'll be talking about the choices of patient of Mitra clips as therapy for heart failure. Here you go, sir.
Welcome, sir, for a